Thank you, Nicholas. And thanks very much for pointing out my true country of allegiance. So I work in Australia, but I'm from New Zealand. They both probably seem the same to you, but when you have a big brother next door, you like to think that you're very different to them. But thank you also to Gabrielle and to Tommaso for the very kind invitation, having a fantastic time here in Pisa. It's a beautiful town, and particularly enjoyed last night going up the Leaning Tower, which was brilliant. So I've been asked to talk to you about the future of the Pelvic Floor Centre. So where are we going in the next 10, 20 years? And I'm just going to present with you, first of all, a bit of an overview of the way that we see pelvic floor dysfunction, its causes, its pathophysiology. And then I'm going to talk a bit about our experience. We set up a colorectal pelvic floor unit at one of the hospitals in Brisbane, and I'm going to talk you through our experience, some of the difficulties that we encountered and how we've ended up where we are today. And then I'm going to present you with my dream of what I think a pelvic floor centre in the future should be. So the problem is obstructed defecation. That is an urge or a want to empty your rectum, but an inability to satisfactorily do so. And it's complicated because there's functional causes and there's mechanical causes and there's other causes. And many of these patients we know have abdominal cramps. They've also got abdominal pain. Many of them will actually present to you saying, my main problem is the abdominal pain, abdominal fullness, I've got a noisy abdomen. And often they'll say, I just feel terrible. And many of those patients will also suffer from fecal incontinence. So half of patients with fecal incontinence will also have defecatory dysfunction. So it's very common, and you should expect to take a history about defecatory dysfunction when you're seeing a patient with fecal incontinence. And we know that can be passive, that can be urge. But it's more complicated than even that, because in fact, if you really sit down and take a more thorough history, you'll find that all of your female patients will probably have around about 8 symptoms. They might have vaginal prolapse, they might have urinary symptoms, but they've chosen to come to you because the obstructed defecation is the problem that bothers them most. Or they've chosen to come to you because it's the vaginal prolapse, it's that pressure in my vagina that bothers me most. Or it might be the urinary incontinence that bothers me most. But when you actually sit down and take a proper history, you'll find they've actually got a little bit of all of these symptoms. They might just have a lot more of one and a lot less of the other. So it's very important to take a history of the anorectal symptoms, but also the urogynecological symptoms. And the problem is a significant burden. There's a social stigma. Often our patients end up isolated. They've got a loss of social supports. They can lose their job. They can lose their marriage. They can even end up suicidal, which is very sad. Fecal incontinence is one of the 3 most common reasons for admission to a nursing home, so there's a significant financial burden to the country as well. And the problems are common. This study was taken from 396 patients who just presented to their general doctor, their GP, for whatever reason. They might have just had a cold or something like that, and they were all surveyed. 11% of them had criteria for irritable bowel syndrome diagnosis, and a third of them had symptoms of a functional bowel disorder. That's a third of anyone walking off the street into a general doctor's practice had symptoms of a functional bowel disorder, of which fecal incontinence was the most common. And there's barriers to treatment. This is a really hidden problem we've found, particularly in Australia, because health organisations do not prioritise functional problems. For example, we have a PR bleeding clinic, a rectal bleeding clinic in Australia, where the only goal seems to be a diagnosis of colorectal cancer. You come in, you get your colonoscopy. Hey, guess what? Congratulations, you don't have colorectal cancer. You are being discharged back to your GP. But doctor, I still have this problem going to the toilet and something poking out and this rectal bleeding. No, just go back to your doctor. You don't have cancer, congratulations. And so there's a lack of prioritization. The patients might be embarrassed. The patients often have a perception that nothing can be done. And not only that, but also the general doctor also has a perception that nothing can be done. And there's a really fragmented service delivery with lack of a dedicated multidisciplinary service that really addresses the needs of these patients. And often, patients often just feel that it's okay to be fecally incontinent because must be just because I'm getting old. But to understand the problem, to understand what's abnormal, what's abnormal about defecation, we have to first understand what is normal defecation, what is required for us to go to the toilet normally and empty our rectum completely? Well, first of all, we need to have a soft stool delivered to the rectum. If we have a big rock coming down, Bristol type 1, it's going to be much harder for us to evacuate. We need to have normal cognition, a normal want to go to the toilet, and defecation is learnt during childhood. It's when we're a baby, when we're an infant, that we learn the technique of how to go to the toilet. And we often learn that off our parents, and experiences and behavioural elements can have a massive influence on how we learn to go to the toilet, and that may affect the rest of our life. Childhood experiences are important, and society often puts pressure on children. For example, your child cannot go to kindergarten until they're toilet's trained. So we end up putting pressure on our children to learn how to go to the toilet. So there's parenting. And unfortunately in Australia, there's a very high rate of child abuse and sexual abuse, and it is not uncommon that, in fact, in our clinic we will uncover that history 40, 50 years after the event, when finally that patient says, this was done to me by someone when I was a child, and I suspect that has had a profound effect on the way that they have learnt how to go to the toilet and potentially been a part of the cause of their problems in the future. We need to have normal sensation, normal neural pathways. Ideally, we need to have an intact colorectum with normal compliance and normal elasticity. But how does defecation actually occur? What actually happens when we're going to the toilet? If we look at conventional colorectal teaching in Australia, what it would say would be that we have puborectalis. Puborectalis is a very important muscle. It wraps around the rectum and it's tonically contracted at rest. So all of our puborectalis muscles are contracted right now, and it maintains the anorectal angle, which is very important for continence. And also contributed to continence is the internal and the external sphincter and the hemorrhoidal cushions. And when we go to the toilet, the puborectalis muscle relaxes, the anorectal angle straightens out, the sphincter relaxes, and we just poo. It just happens. And that's about as far as the teaching in Australia goes. And I've had a look around, a bit of a Google search, and in general that's what you'll find. That's normal defecation. But is that really what happens? Because this study looked at 20 patients who were undergoing dynamic MRI during defecation. These patients had no symptoms. They were normal volunteers. And interestingly, what could be seen during defecation is that the anorectum was actually pulled open both posteriorly and anteriorly. The posterior rectal wall moved backwards and the anterior rectal wall moved forwards. So how can that possibly happen with our current hypothesis of normal defecation, which is simply just puborectalis relaxes? There must be some active muscular contraction. And with this, the anal canal increased to twice its diameter during defecation, which of course makes physical sense because it's going to be much easier to go to the toilet if your anal canal is pulled open. So these observations can only occur with an active contraction of muscle during defecation. So it's not just simply a relaxation phenomenon. There must be some active muscle contraction in the pelvic floor that occurs during defecation, and this makes mechanical sense. So perhaps we can look at a new theory of what actually occurs during defecation. This new theory here looks at the puborectalis muscle, again being important. At rest, it's tonically contracted and pulls the rectum forward. The levator plate and the longitudinal muscle of the anus then pull the rectum backwards and downwards, and that will also help to maintain that anorectal angle. So that's at rest. During defecation, the puborectalis muscle relaxes, but pubococcygeus, which is actually attached to the front wall of the rectum, contracts to pull the rectum forwards, and the levator plate and longitudinal muscle of the anus continue to contract, but now unopposed by the puborectalis contraction, thereby pulling the anorectum posteriorly. And perhaps this hypothesis would fit a little bit more with what we saw in those dynamic MRI images. So perhaps the anal sphincter is a little less important in anal rectal function than we originally thought. We know that there are important rectal and pelvic supports that allow pelvic floor function, and the presence of these supports may be important in function. If we're able to restore normal anatomy, then we may be able to restore normal function. We've got the uterosacral ligament, the cardinal ligament, a number of other ligaments, but there was no ligament that we were born with that joined the front wall of our rectum to the sacral promontory. There was no ligament we were born with that joined our cervix to our sacral promontory, yet that is currently what we do for patients with pelvic organ prolapse. And so our current operations are non-anatomical, and perhaps if we're able to create a more anatomical repair, that might lead to better function. And this would be supported by this study by Liedl et al. From Germany, 2017. This was a large multi-center prospective series over 600 patients, and these patients all had vaginal prolapse. But they had vaginal prolapse and 2 other pelvic floor symptoms, and of the 611 patients, 93 of them had fecal incontinence as well, and 194 had chronic pelvic pain. And all of these people simply underwent a transvaginal reconstruction of the uterosacral and cardinal ligaments. No operation on the anus. The anus was not touched, just a ligamentous reconstruction. And all of the symptoms improved statistically significantly, including fecal incontinence. So these patients had reconstruction of the uterosacral and cardinal ligaments and a significant improvement in their rate of fecal incontinence, no anal surgery. So muscular function of the anorectum and bladder may require ligamentous support, as suggested by this study. And we were noticing the same thing in our series of patients at our local Brisbane hospital. What we were noticing was that if someone came to us and they said, I have fecal incontinence and defecatory dysfunction, but I also have vaginal prolapse, and the vaginal prolapse is pretty bad. What we were finding was that when a gynecologist was operating on them for their vaginal prolapse, and they came back to us, they said, my vaginal prolapse is better, but so's my anorectal dysfunction. My fecal incontinence is also better. My defecatory dysfunction is also better, but no one touched their anus, no one touched their rectum. So we wanted to look at this in a little bit more detail. So we've just put this paper together just recently. So we looked at all patients who presented with synchronous vaginal prolapse and anorectal symptoms together. We looked at all of the patients who underwent a sacrospinous fixation and transvaginal prolapse surgery, and we looked at all the patients that we'd seen before they had that surgery and after they had that surgery. Our record search identified 15 patients. This was a retrospective observational study, and so all these patients, they came with vaginal prolapse and anorectal symptoms, and what they had done was they had a gynecological operation by a gynecologist, they had a sacrospinous fixation, and almost all of them had a posterior colporrhaphy. A lot of them had an anterior and posterior colporrhaphy, and 40% also had a vaginal hysterectomy. And all of these patients were seen, and they filled out validated quality of life and symptom severity scores before that surgery and after that surgery. So our mean follow-up was 6 months. And interestingly, what we noted was that there was a significant improvement in all, an improvement in all of the scores. The constipation score, the fecal incontinence score, the quality of life scores for both of those things. And even with only 15 patients, we were able to achieve statistical significance for about half of those measures. So quality of life for constipation, obstructed defecation, CSS score, 2 elements of the fecal incontinence quality of life score, and the PHYSI score, all statistically significantly improved without the anus or rectum being touched, supposedly. So vaginal prolapse surgery can improve anorectal symptoms. What else is required for normal defecation? We need to have a coordinated abdominal, rectal, and pelvic floor maneuver. We need to open our anus, and we need to be able to push down. And some patients can develop disordered defecation where that does not occur. We talk about the abdominal cylinder. Physiotherapists will think about the diaphragm, the abdominal wall muscles, and the pelvic floor muscles as one unit, and direct therapy at the entire abdominal cylinder to try to improve defecation. Some patients will actually, with severe disordered defecation, will actually actively close their anus and then push against it. And they think that's normal. They think that's what they do when they go to the toilet. So we've got a case that came through our doors a few years ago. He's a 23-year-old male, and his whole life he had suffered from terrible constipation, terrible bladder emptying problems. He had encopresis when he was at primary school. By his teenage years, he had already developed passive fecal leakage. He'd been in and out of hospital his whole life, all these behavioural issues, and he had a lot going on at home. I think he had a very traumatic upbringing. His father killed himself when he was 7 years old. By the time he was 17, he had such bad symptoms that he saw a general surgeon, and the general surgeon gave him a loop ileostomy. He came to us with this massive peristomal hernia containing most of his small bowel, and he told me that he was going to kill himself as well because of this constant terrible pain he had around it. So we looked at his pelvic floor. We tried to work out what was going on. Why could he not go to the toilet? And it was fascinating. We found that even at rest, he had these short-lived, frequent pelvic floor contractions at rest. He had a high resting tone, but his squeeze was poor, and that's something we often see with disordered defecation. He's a young male. He should be able to squeeze his anus tightly together, but he can't. But at rest, he's got a high tone. Very strange, but something that we see very commonly, in fact. So this is his endoanal manometry. So this is at rest. So at rest, he's constantly got these intermittent contractions of his pelvic floor all the time. When I ask him to squeeze, he can do a short squeeze, but then peters out. And when I ask him to push to go to the toilet, he squeezes almost even harder than when he's actually trying to squeeze to close his anus. So his defecation is completely disordered. This is his proctogram. We put some barium paste in his rectum. Sorry, the images are not that good. And he was unable to evacuate any of the barium at all in this study. So we did a rectal biopsy to exclude Hirschsprung's disease, so he didn't have Hirschsprung's disease. And then we said to him, look, we're going to have to spend a lot of time. We talked about enemas, we talked about retraining, physiotherapy, biofeedback, antegrade irrigation. And he just turned around and he said, look, I don't think I'll ever be able to go to the toilet properly. I'm happy to just spend the rest of my life with a colostomy. So we reversed his loop ileostomy and gave him a permanent descending colostomy. So what are the causes of anorectal dysfunction? Why do people run into trouble? This is all hypothetical. This is hypotheses. I can't prove any of this that we've come up with from our experience in seeing these patients. There are, of course, iatrogenic and medical causes. If you have a sphincterotomy or a fistulotomy or a resection, of course, that is something that we see. But that's actually the small minority of patients that come through our doors. The most common cause in our experience is obstetric trauma, which is why 80% of our patients are female. It's because the most common cause is tearing of those important ligaments during childbirth. Hysterectomy, we've also found it's not uncommon that someone will have a hysterectomy and then come to us saying they've got anorectal dysfunction. That is slightly controversial in the literature, but that's certainly been our experience. But then there's quite a large group of people who just have a poor technique that they may have either developed from childhood or developed later on because of psychological trauma or physical trauma or other events. And then, of course, there's the strainers. There's people who just have a hard stool, poor diet, unhealthy eating, or medication. So the theory is that initially there may be a high pressure or straining. So patients strain and expose their rectum to high pressure for years and years and years and years, and they stretch things out, which leads to a loss of effective biomechanics, which means they have to strain more and they end up in this vicious cycle. Some people may lose biomechanics as their inciting events, such as obstetric trauma, such as surgery, and because they've lost biomechanics, they have to strain more to evacuate, and they end up in the same cycle. But this seems to be the same underlying problem that underlies anorectal dysfunction. So it's complicated, as I'm saying. There's functional disorders and structural disorders. And I think if we just look at pelvic floor dysfunction as something structural that just needs a surgeon to come along and fix an anatomical problem, but ignore the functional side, I think our results are not going to be as good as if we address the whole problem. So it requires a thorough history, a thorough examination, judicious use of investigations, and careful selection of patients for operative intervention, because we have to look at all the symptoms. More than half of people with fecal incontinence have urinary incontinence, and of rectal prolapse patients, more than half of them have urinary incontinence as well. So we need to look at the whole picture, and we've got a real problem in Australia because our current approach, our current paradigm leads to unicompartmental treatment. If you have fecal incontinence, you see a colorectal surgeon. And if you say, oh, I also have urinary incontinence, the colorectal surgeon will say, oh, you need to see my friend up the road, the urologist. And we end up with this unicompartmental treatment. We're not really addressing the whole problem. And the complexity of it really lends itself well to a multidisciplinary approach. We can do this. This will optimize patients' care. We need to understand each other's roles, need to be able to discuss complex cases and perhaps operate together, which is always enjoyable. We always enjoy operating with our gynecology or urology colleagues. But is this really the answer? Is that really the way forward for the future, the next 20, 30 years? What about a specialist pelvic perineologist? What about training a new generation of surgeons who actually address the entire pelvic floor as one? They're trained by colorectal surgeons, gynecologists, urologists, but they're able to take a thorough history, perform an appropriate examination, and understand how one thing affects the other, because this seems to be the case. Maybe that's the way forward. So our experience in Queensland and Australia is that there was already a very well established functional urogynecology unit at a small hospital in Brisbane. It was not a large hospital. The problem with setting up pelvic floor services in large hospitals is that cancer and trauma always trump them, and they're always the poor cousin, and their patients are not prioritised. We also were very lucky to have an experienced pelvic floor physiotherapy service already there. So we started our service in 2014, and most importantly, we have a dedicated colorectal nurse specialist. We now have 2 of them. And these people are absolutely integral to the service, and without them, the service would not run. We started with 1 colorectal surgeon, who was me. We've now increased to 5. So we had our lab approved in February 2014. I think it's important to discuss funding issues, because we all work in a resource-limited environment, and we're no different in Queensland. What we've certainly found is that functional disorders and disorders that affect quality of life are now becoming sexier when you're talking to health ministers, health boards, and there is now more interest in qualitative research and qualitative work. And often health industries seem to go through a cycle where there's some money, and then there's no money, and then there's some money. So it's just a matter of timing your application when there is perhaps more resources. And we were able to secure funding to set our lab up, and then we started multidisciplinary team meetings with urology, gynae and physio, where we sit down and talk about complicated cases. And we started off really treating patients conservatively as much as we could, but then as they completed conservative therapy, some patients needed surgery, and we started doing more and more of that early in 2015. Our most significant advance, I think, was our physio-led clinic. So we were able to secure funding for dedicated pelvic floor physiotherapists to work in our functional unit. And so what happens is that patients go on a waiting list to see us, to see the surgeon. And the pelvic floor physiotherapists can access that waiting list and can take patients from that waiting list and see them and start treating them. And what we were finding was that many of those patients, by the time they came to see us, they were fixed. Or if they weren't fixed, they were significantly improved to the point that they didn't need any operation. Sometimes we've got, and it's important to have good communication with your physiotherapists, good communication channels. So sometimes the physiotherapist will contact us and say, look, I've seen Mr. X, or Mrs. X usually, and they're now significantly better, and what I'll do in that case is I'll change the appointment to a review appointment, and I'll see the patient and they'll say, look, I'm happy now, I know what to do going forward, and I'll just make sure they don't need a colonoscopy or something like that, and discharge them. So this has been a significant advance to our service. And then in February 2016, we started a dietitian-led clinic as well. So patients with both obstructed defecation and even fecal incontinence are now also seen by dietitians before we see them. And in my next talk later this morning, I'll present to you some data on results from our dietetic-led clinic. In December 2017, we got funding for a research assistant. So finally, we're able to convert some of the data that we've collected over years into research, and so that's going to be coming out. We're going to be publishing more soon. And just recently, earlier this year, we now have a dedicated operating list where we operate together with the urogynecologists, and we've certainly found that very enjoyable and very valuable for our patients. So far, we've seen over 1,500 patients. We spend a lot of time with the patients is the thing. So each new patient will have a 45-minute consultation. Sounds like a long time, it is a long time. But that'll include a long history, a full anorectal physiology assessment. We'll also request all appropriate investigations. We'll discuss with them basic medical management. We'll prescribe for the medications. talk to them about an approach going forward. So it does take a lot of time. And so about 82% of our patients are female. Interestingly, many of them come to us having had no basic medical treatment. Even if they're referred by their GP, many of them may not have even been started on a fibre supplement or a laxative or something simple like that. So we find ourselves often having to do some really basic things. 18% have undergone surgery at our unit, and I think that stat speaks for itself, and that the number of patients who end up not needing surgery because with the basic conservative non-operative measures they've been able to get better to the point that they don't feel they need an operation. And our overall satisfaction, I would say, is very high, and I think that's largely because people with these pelvic floor problems often seem to have gone from doctor to physio to alternative practitioner, back to a specialist, and they've had 10 colonoscopies, but no one sort of addressed this problem. And so because we sit down and explain the problem to them, they leave, many of them actually leave in tears because they just feel that their problem is finally being addressed. This is what people are coming to us with. So the most common presentation was obstructed defecation, fecal incontinence, and then a smattering of other things. 8% had chronic pelvic pain. This is our lab that we set up, and this is where we see most of our patients. These are our nurse specialists, so these people are crucial. They've been with us for years now. They manage all the bookings, and all of our patients, every time we see them fill out these validated questionnaires that I was talking about before, and that's mainly for research purposes, to be honest, but it does give us an idea as to whether our treatment is making patients actually better or not. They assist with anorectal physiology. They're the first contact for patients, so if patients have problems or they feel they're getting worse or they're really in trouble, there's a phone number they can call these people on. So they sort of know most of our patients, which I always find quite amazing. They can educate patients on bowel retraining and retrograde irrigation like peristine, which we're using more and more of. Our nurses are formally trained to educate patients on how to do that as well. They oversee all the referrals, so if someone is referred to us and they're very symptomatic, then the nurses will increase the priority of that referral. So we do a lot of things with that. When we first see someone, we do a thorough history and a thorough examination, as anyone would. We do anorectal physiology, including all the usual tests, manometry, rectoanal inhibitory reflex, sensation, ultrasound, pudendal nerve, EMG, and then we occasionally will request a proctogram, and then we'll consider endoscopic investigation as well for completeness. And how do we know what to offer people? Well, this is why we have these congresses, because it's really difficult. There's non-operative measures that we've talked about, SNS, sphincter repair, levatoplasty, rectopexy, and this is not complete, as you know. There's many other potential options as well. So it's a matter of trying to work out what is likely to make this patient better. Our general approach is that we screen for secondary causes of symptoms outside the pelvic floor. So we look for luminal disorders, we look for endocrine disorders, hardly ever find that, but occasionally we do. There's a rapid referral to physiotherapy and dietetics and close communication with them. Chronic pain clinic, it's important to have a close alliance with them, and psychology, and as I said, a single point of contact for patients. We do have a low threshold for endoscopic assessment. We wouldn't want to miss anything, and we have access to all the imaging. And generally, our general plan is to reserve surgery until a trial of conservative therapy, because occasionally you're surprised. You might see someone and you think, oh, this patient, I'm going to need to end up operating on them, and you get surprised. They come back to you and they say, you know what, I'm happy now. I've had some physiotherapy and dietetics, and I've done this and I've done that, and I've worked this out, and I don't really think I need an operation, at least for now. Significant diagnosis rate of 1.5%, so we've picked up some colon cancer, a pancreatic cancer that presented as fecal incontinence, very weird, and some arachnoiditis. So how do our tests help? Is it worth doing all this? Is it worth spending all this time doing this anorectal physiology? We know, as we heard from Yasuko's talk yesterday, endoanal manometry has a very poor correlation with symptoms, and it's not predictive of a response to treatment. Rectal sensation testing can be useful because it predicts a poor result of surgery. Ultrasound, I guess, really is only helpful if you're considering actually doing a sphincter repair. And pudendal nerve latency has really been abandoned in many parts of the world. And this study from 2017 looked at all these variables, which of these were actually associated with worse fecal incontinence, and they only found 3, which was an external sphincter defect, pudendal nerve latency, interestingly, and previous pelvic surgery, interestingly, especially hysterectomy, but none of the other variables were actually associated with worse fecal incontinence. So is it worth doing routine anorectal physiology? Is it worth doing proctography? It's controversial, and we know as well from yesterday that certainly these tests may have a medico-legal role, but I would argue that there appears to be a limited utility over a thorough history and examination. It'll be useful if you can pick up a sphincter defect. If you're looking at sphincter repair, altered rectal sensation, it can be useful, but what else? What about the educated finger, along with a thorough history and examination? And we've found that can actually be very accurate. We do perform some surgery for high-grade internal rectal prolapse where the rectum intercepts right down into the distal anal canal. And what we've found is that the digital rectal examination can be sometimes more accurate than proctography. We had a group of 22 patients in our unit who we suspected, based on digital rectal examination and history, were probably going to benefit from having a rectopexy. They probably had high-grade internal rectal prolapse, and all of their proctograms were negative. This is a group where the proctograms were negative, and what we found that in 20 of those patients, they actually did have high-grade rectal prolapse when we did an examination under anaesthetic, and many of them did benefit from having a rectopexy. How severe are their symptoms? As I say, we have routine filling out of questionnaires. It does take a lot of time. It's mainly for research purposes that we do that. So what are our results with this service? Certainly there's been an overall improvement in all patients undergoing non-operative therapy or undergoing operative therapy. These are slightly earlier results from our experience, but all our patients undergoing rectopexy surgery had an improvement in both fecal incontinence and constipation scores. Patients undergoing peranal delormes had similar benefits with both fecal incontinence and constipation. Our non-operative treatment patients also had an improvement in their symptoms. Obviously, I'm comparing apples with pears here. This is just to give you a snapshot of what our patients are doing. Their improvements were quite modest, to be fair, but I would also comment that the patients did have a very high level of satisfaction with the service. So what's my dream for the future of a pelvic floor clinic? Who should the patients first see when they come and present? I've spent a lot of time thinking about this, and I really am not sure, but I wonder if that person should be a doctor who's able to take a relevant history and a focused pelvic floor examination, but importantly a doctor because they can screen for secondary causes, request appropriate tests, follow up results, prescribe medication, so they can initiate basic medical therapy. They need to be passionate about the field. They need to be able to reassure patients that their symptoms will be addressed by the service and that the patient will not be abandoned. They need to be able to detect significant problems like a full thickness external rectal prolapse, for example, that might require upfront surgery. There needs to be an early pelvic floor physiotherapy input, as I've shown. I think also early dietetic input as well. And the clinic would need to be a single point of contact for all patients so that they can easily access this service, which is going to always be there for me. Needs to have easy access to other services, gastroenterology, chronic pain, etc. And I'd like to see all specialist surgeons spend time working together and operating together with the goal of training a future generation of pelviperineologists, if that's what we like to call it. There needs to be a focus on understanding the whole pelvis and tailoring an intervention to treat all of the patient's symptoms that they present with, and research into perhaps an idea, a more anatomical repair of disrupted connective tissue might perhaps achieve a better, more predictable result. Thank you.